Good afternoon. My name is Yuda Zicherman, and I would like to thank to the organizers of this conference for putting together such interesting sessions, as well for inviting us to participate. So as you well know, ultrasound is one of the most useful evaluations tools around. But in fact, it is underutilized, especially in the point of care in hospitals and in the community and primary care physicians. So, how we make ultrasound available for emergency room and primary care clinicians, especially in cases when the clinician is not a trained echosonographer. Number one, by making sure that any doctor, even one without proficiencies in using ultrasound, can get optimal readings. And number two, by making it possible to use those readings to make meaningful decisions to the next best step for the patient. So, by integrating artificial intelligence into the echo diagnosis procedure, a handheld ultrasound device, we believe, that costs a few thousand of euros, has the potential to become a leading diagnosis tool for community clinicians. Last year, we presented our methodologies for developing the technology for primary cardiology care. Let us see now, a year later, how we do it in real time on humans. So we pre-recorded the typical examination of a patient in a clinic. You will be able to see exactly how the system evaluates the operating performance toward optimal acoustic window, both position and quality. We will also see how we derive qualitative and quantitative outcomes of 10 different parameters readings that can be used to determine the next best step with the patient. Also, you will be able to see how much time a typical procedure takes from the beginning of the echo process until its completion. We call it 2 positions and 4 different views in under 5 minutes. So the first case concerns a 40-year-old male who scheduled a routine visit to his family physician clinic. As a part of this routine, an initial cardiac assessment is made due to the visitor's family history. An AI-powered handheld probe is used to search for outcomes in 4 echo views. The first is subcostal 4-chamber. The system indicates with a different set of colors how optimal the view reached by the physician is. An optimal view is obtained with a few steps. Then the system automatically calculates the RV over LV ratio and whether pericardial effusion is visible or not. The results are presented immediately after. You can see in our case that RV over LV equals 2/3, which is normal. Then the system guides the doctor to rotate the probe and reach the next view, subcostal IVC. Once an optimal view is reached, the technology calculates IVC size, whether dilated or not, and the collapse rate. You can see that the IVC size in our case is normal and IVC collapse rate is more than 50%, which is normal too. Both outcomes are shown in the new results together with the previous ones obtained in the subcostal 4-chamber view. So, as the examination continues, the clinician is asked to move the probe to a second acoustic view to get the apical 4-chamber view. The same methodology is used to assist the user to get the right view at the right new spot. As before, the results are presented. Now it includes left ventricular volumes, meaning end-diastolic volumes and systolic volumes, stroke volume, ejection fraction, cardiac output, and heart rate without the need to connect to an ECG. You can see that the end-diastolic volume is 103 milliliters and end systolic volume is 42 milliliters. Stroke volume is calculated to be 61 milliliters. Ejection fraction is calculated to be 59%. Cardiac output is 1.4 liters per minute, and heart rate is 72 beats per minute. These outcomes are added to the previous results from the subcostal view 4-chamber and IVC. Finally, using the same methodology, the technology guides the user to reach the apical 2-chamber. The results are presented in a final report. You can see that EDV, ESV, and SV has been slightly changed. The reason is that final results are based on the biplane Simpson method rather than just the monoplane Simpson as seen here. As presented, the technology instantaneously and automatically presents the cardiac parameters that are believed to be relevant to the ER and the primary care clinician. In this case, normal results are recorded, and the clinician can make his decision accordingly. The whole procedure takes about 5 minutes. So we would like to ask you, are these results sufficient? Do you think that the methodology is intuitive enough to help you in your practice? And we will welcome your feedback. The second case concerns a 50-year-old man who complained of a recent onset of shortness of breath and fatigue. Upon examination using a stethoscope, the heart sounds were normal. Other parameters were such: blood pressure 103/68 millimeters hydrogen, heart rate 100 beats per minute, respiratory rate 14 breaths per minute, and weight is 83 kilograms. We follow the same procedure and begin with subcostal 4-chamber view. With this specific patient, you can see that the technology detected right ventricle enlargement compared to the left. Ventricle and pericardial effusion are not visible in this view. Might be due to the fact that apex of the heart is not fully visible in this view. You can see that view equality indication is moderate, orange color, which reflects the missing sector of the apex. A moderate view quality is calculated by the AI, but may have limitation that the next view may overcome. In case only a poor quality view is reached, the system can be overridden by the operator and move on to the next view. As before, the system asked the user to move to the subcostal IVC view. Subcostal IVC view shows dilated IVC and mild IVC collapse rate below 50%, which corresponds to the enlarged right ventricle that was detected in the subcostal 4-chamber view. The revised results page is presented. Now continue to the apical 4-chamber view. You can see that the right ventricle is enlarged compared to the left ventricle as detected in the subcostal 4-chamber view. But, moreover, new information is detected by the system due to the complete green color view that includes the whole apex in the apical 4-chamber view. A mild pericardial effusion is visible around the right ventricle and apex. This is indicated on the result page in addition to the left ventricle volume calculation, which means the ejection fraction, cardiac output, and the volumes. Finally, using the same methodology, the system guides the user to reach apical 2-chamber. The view deviated from the expected picture, and therefore, the AI does not designate the view as green. Though it is an issue that our AI application should do in the future, the difficulty to find a green view in this case also indicates clinical findings. The shape of the left ventricle is unusual in this case due to the right ventricle enlargement. So we have our deficiency, but it's derived from clinical reason. You can view the final results page that was obtained again in less than 5 minutes. So the outcomes are: the right ventricle is severely enlarged, the IVC is mildly dilated and does not collapse. The EF is normal. The findings justify referring the patient to a more extensive cardiology examination such as full echo exam. To sum up, from our perspective, mission accomplished. And now we eagerly await your feedback. We will have a Q&A session at the end of our presentation. I would like now to share with you a few words from TRISO's founder, Dr. Binyamin Shadi, who is a visionary practicing cardiologist.
Echocardiogram is a very useful tool. It's used all the time to evaluate cardiac function, and I had ideas how to get the data from it quantitatively, which is not readily available or very more routine than an EKG, I think. Stethoscope is very quick and easy. This involves a little gel on the chest, but if you immediately get results and you need to see what the what's the cardiac output, what's the LV wall thickness, the data that you get, the results you get, are the value of it is so great that it could be that it could become a routine tool that you would do it on every patient.
A quick spontaneous interview with Dr. Polyak, a radiologist and medical executive who acts as a company clinical advisor. Dr. Gabi Polak, you are a radiologist and senior manager in a big hospital, in a healthcare system, HMO, in emergency care services. What made you so enthusiastic in point-of-care ultrasound that you joined this project?
Well, I'd say the major thing that really made me enthusiastic is truly the major impact that I can see on the three players in the system, on the patient, the physician, and the health system itself. Whereas today the process is cumbersome. The patient usually gets sent from the primary care physician to a specialist who could be a radiologist, a cardiologist, etc., at a separate location at a different time, which is quite a cumbersome process. Here, what we've done, we've managed to shorten the diagnostic process in a major way, which really results in a quick, an immediate, instant, and in real-time diagnosis. So we've created a bedside diagnosis, a new and sophisticated tool that really enables the primary care physician to come to a fast diagnosis on spot in real time. That is a major difference for all these three players. The fact that the primary care physician can come to a diagnosis immediately on the spot without sending the patient to a specialist has a major impact. This definitely is the new stethoscope, and the newer generations will be medically trained using this device, and I would say that in 5 to 10 years' time, there will be no question at all. This will be the gold standard and the common practice.
Now, I would like to show you a short interview that we recorded with Dr. Amir Shachar, who is Director of Emergency Department in Laniada Hospital. Amir will be conducting a clinical trial next month on 50 patients using the TRISO system and compare the results to those of trained sonographers.
In the nearby future, the patient will have quite a new and fantastic way of his examination in the emergency department. Guided echocardiography will be primary and essential step in evaluating the patient with chest pain in the emergency department and will provide both the nurse and physician with medical information that will lead him to the diagnosis in another new and more efficient way of evaluating him in the emergency department.
As promised, we will move to the Q&A session for the time remaining. We will do it with our clinicians, Dr. Gabi Polak, who is a senior medical executive, and Michal Binelbaum.